Good afternoon or morning, depending on where you are joining us from. It is 3 p.m. Eastern Time on the dot. I'm going to give folks another minute or so to log in and get situated, and we will start our webinar briefly. Thank you.
All right. Hello, everyone. I'm going to go ahead and get us started for our webinar, Trauma-Informed Approaches. I'm going to go ahead and start recording, so please give me a moment. Oh, actually, I see the session is already being recorded. All right. So we will go ahead and get started then. Again, I want to welcome everyone to today's webinar on trauma-informed approaches for both Ryan White Part B and ADAP programs, as well as for our prevention colleagues. My name is ETIQUETTE. I serve as a manager on the healthcare access team today. I'm going to go ahead and jump right in. Just wanted to cover some sort of housekeeping items and webinar etiquette. So all of your phone lines are muted and will remain muted for the duration of the webinar until we get to question time. If you would like to be unmuted so that you may ask your question verbally, please raise your hand using the controls on the right bar on your screen. As I mentioned, there will be time for verbal questions during the Q&A portion at the end of today's webinar. Please identify yourself when you're asking a question or providing a comment. Any written questions you may have, there is a questions functionality, again, on that bar on the right corner of your screen. If you would like to type in your question as opposed to verbally asking it, I encourage you to enter in those questions throughout the duration of the webinar, and we will get to them, as many as we can, at the end of the webinar. If we're not able to respond to your question during the webinar, we will follow back up with you via email or phone call and the like. At the end of this webinar or tomorrow morning, you should be receiving a memo from myself with an evaluation for the webinar. Please, please, please complete that webinar. That's really helpful to us as we develop future webinars and technical assistance for you all. And then lastly, because we receive the question often, I will be sharing the slides as well as the recording for the webinar in follow-up. If I can get the files onto an email and they're not too large, I will send that along with the evaluation. Otherwise, it will be available on NASDAD's website. The last thing I do want to mention is there's also a chat box feature again, in that bar on the right side of your screen. If you would like to share any comments or if you need to communicate with us here at NASDAD, please feel free to do so through that chat box feature. All right, and so now we're going to jump into the content for the webinar. We like to share this trigger warning because today's topic can be sensitive for folks, just the discussion of trauma alone can be triggering. And so we want to encourage you all to be kind to yourself. If you need to just take a break or step away as a precaution or just for mental health reasons at any point throughout the webinar, we encourage you to do so. As I mentioned, the slides and recording will be available to you later on in case you would like to circle back and tune into what you missed. So an overview of what we'll be covering today. The first portion of our webinar will be around understanding trauma, and so a bit of the background, or a trauma 101 as I like to call it. And then we will be reviewing the toolkit itself. And so the one thing I do want to mention, for those of you who have seen the Trauma Informed Approaches Toolkit already, you've probably noticed that the first half is a lot of that background, and the second half is very much literally a toolkit or a how-to guide. What I'm referring to in this portion here is that how-to guide that we'll be providing an overview for. Next, we'll move on to some discussion and question and answer for us or for one another if you would like to discuss anything. And then lastly, I have a few calls to action that I would like to share with you all. So we're going to kick off with a poll. And I'm going to hope that technology does not fail me. If this does not work well, it's totally fine. We'll just move along. But the first poll, okay. So hopefully you all should see the first poll popping up on your screen right now. The question is, how familiar are you with trauma-informed approaches? So I'm going to give you all about 30 more seconds to respond to that. Again, you should see the poll on your screen right now. The question is, how familiar are you with trauma-informed approaches? The three options are very familiar, familiar, or not familiar. And again, final reminder, you should see a poll on your screen right now. The question is, how familiar are you with trauma-informed approaches? The three response options are very familiar, familiar, or not familiar. And so now I'm going to close the poll. And so hopefully you all can see the results on your screen, but the results are 9% of you all reported that you are very familiar with trauma-informed approaches, 61% of you all are familiar, and then 30% of you all are not familiar. And so I want to thank all of our participants for responding to that. It's exciting to see that this is a new concept for some of you, and some of you maybe have a little bit of familiarity, and I hope you get just a little bit more of an understanding over the course of today's webinar. So we're going to start off with understanding trauma. And so what I have on your screen is, first of all, the definition of trauma that a NASDAD is sort of adopting or moving forward with. There are many definitions of trauma out there. We don't feel as though any one is more correct than the other. This is just the definition of trauma that we're going to be operating with. And then next, trauma-informed. So this is a term that maybe you've heard us use a bit, maybe you've heard others use a bit. And so what it basically is an approach to administering services, in our case, HIV prevention and care, that acknowledges that traumas may have occurred or are active in our clients' lives, and that those traumas can manifest physically, mentally, or behaviorally. And so what we want to do is work to become trauma-informed, and then we also want to take trauma-informed approaches to our care and prevention services. TIC versus TIA. Here we go with our fun acronyms, as we love. So TIC stands for Trauma-Informed Care. TIA is Trauma-Informed Approaches. So I wanted to clarify this because this is, I think folks get hung up on this sometimes. What you probably hear more often is trauma-informed care, which is great. It is, however, only one type of trauma-informed approach. There are many strategies, action items, and approaches you can take outside of providing trauma-informed care. It is a very imperative and important part, so I don't mean to undermine it. It is extremely important, but what we want to do is encourage folks and push folks to think more broadly. So what are some of the policies, programmatic practices, etc., that you all are operating with or under and imposing upon your subrecipients that maybe have some room for becoming more trauma-informed? So continuing along, so providers are developing a more comprehensive understanding of trauma, including through the concept of neuroscience. NEUR is an acronym for neurobiology, epigenetics, adverse childhood experiences, and resilience. Neuroscience provides a holistic understanding of how trauma impacts health outcomes. And excuse me, I'm going to be walking you through each of those the letters of NEUR and explaining a little bit about what they are, what they stand for. So we're going to start off with the N, neurobiology. So these are the three parts of the brain that we're going to focus on for the purposes of understanding trauma better. The prefrontal cortex is known as the thinking center. When this area of the brain is strong, we're able to think clearly, make good decisions, and be aware of ourselves and of others. Research indicates that after trauma, particularly trauma during childhood, the prefrontal cortex's integrity is compromised and is less able to communicate with other parts of the brain. Moving along to the hippocampus. The hippocampus is known as the emotion regulation center. When this region is strong, we're able to manage difficult thoughts and emotions and recall and recognize memories. So, for example, when you smell a certain perfume, it reminds you of your grandmother. That is likely your hippocampus in action. However, in contrast, individuals who have experienced traumatic stress may experience vivid memories or persistent thoughts that are reminiscent of a trauma. So, for example, and this is one of the times where I'm going to throw out a trigger warning for folks, perhaps you smell a scent that reminds you of your grandmother, and that is actually a negative memory. Perhaps this person that is experiencing, has experienced trauma, experienced it at the hands of their grandmother. And so for these folks, they may have a difficult time distinguishing between a memory as a thing of a past or a current threat. And then finally is the amygdala, which is known as the fear center. This fear center responds to stress and anxiety and coordinates a behavioral response that helps to ensure survival. Many of us have heard of the fight, flight, or freeze response, and the amygdala is what is responsible for those responses. For example, imagine you're walking down a hiking trail and suddenly you see a snake. And then with lightning speed, your amygdala reacts to that snake before you even consciously really notice it's there. And the amygdala is helping you to react quickly when there is a threat in the forest, so to speak. But this can be a problem for someone who has experienced trauma, because in the traumatized brain, the amygdala is on high alert. And this often leads to inappropriate or erratic, defiant, etc. Behavior, as the brain is unable to access the prefrontal cortex and apply logic to the situation. The A. So this is the A in neuroscience. I recognize we have skipped the E for epigenetics. We'll be circling back to that in a moment. So A, adverse childhood experiences, or ACEs, as they're often referred to as. So the original ACE study was conducted at Kaiser Permanente in partnership with the CDC from 1995 to 1997. And during this time, over 17,000 people receiving physical exams and completing confidential surveys regarding their childhood experiences and their current health status and behaviors. And the survey that they completed included questions like, while you were growing up, during the first 18 years of your life, Did a parent or other adult in the household often swear at you, insult you, act in a way that made you afraid that you might be physically hurt, etc.? And as you can see, that first circle icon on your screen of physical abuse, this question pertained to that ACE, or adverse childhood experience. Now, they asked similar questions for these 8 factors that you see on your screen right now. I'm not going to go through all of them for the sake of time. But what they did learn from this study is that, in fact, the more adverse childhood experiences that an individual has had, the more likely they are to experience negative health outcomes in the future. And so what I wanted to do here is share with you all a real-world application of ACEs and the effect of them and how it's relevant to the populations that we work with in HIV prevention and care. And so our colleagues over at the Iowa State Department of Health graciously shared with us some of the data that they collected through their 2016, HIV consumer needs survey. And what they've done is compare that and do a sort of side-by-side of Iowa as a state results for the ACEs survey in the Behavioral Risk Factor Surveillance System, which we affectionately refer to as BRIFIS. And so what you all will learn before I jump into the details is that in BRIFIS, some states have decided to include ACEs because of the strong correlation and how much research has shown those are indications of adults' health outcomes. So a lot of states have moved to include the ACEs survey in their BRIFIS. And as you all likely know, every state completes a BRIFIS. And so circling back to what Iowa did here is that they included those ACEs questions in their HIV consumer needs survey. And how ACEs are scored is that if you report no to the questions, like the example I previously provided, if you respond no, you get a 0 for each question. And there is a total of 8 questions for those 8 factors that we were just looking at. So what we want to see is 0 being a very high percentage. That indicates that no one has had an adverse childhood experience. Unfortunately, that is not the reality. As you can see here, across the state of Iowa, that is the yellow, the higher up you get in your ACEs scores, the sort of lower it starts becoming for the general population in Iowa. Unfortunately, that's not exactly the trend we are seeing for our clients. And when I say our, what I really mean is Iowa. And so you can see for the 6 to 8 adverse childhood experiences score, there is 16% of people living with HIV who've reported that number. Whereas in the general population of Iowa, you see that only 5% of those participants that responded to the survey reported 6 to 8 ACEs. And so this is important because it provides us a pulse on what is going on in our client population and whether we need to be tailoring our services to be trauma informed. I'll get a little bit more into incorporating ACEs later on in the webinar. And so now we're going to hop back to that E, epigenetics. And so what I wanted to share about epigenetics, it is a somewhat dense concept to understand, to just be transparent with everyone, but I want us to just focus on a simple definition of what epigenetics is to begin with. So the study of epigenetics is a study of biological mechanisms that will switch genes on and off. And I'll repeat that again. So epigenetics is the study of biological mechanisms that will switch genes on and off. And I share that definition with you all so that it makes a little bit more sense as to how this relates to trauma. And so as you can imagine, those genes being switched on and off can have implications for your health outcomes. And so there was a group of folks a few years ago that on the left-hand side, you will see the conceptual framework, which is a pyramid, for the adverse childhood experiences study, right? So they evaluated this conceptual framework, this pyramid, and they said, this is great. However, we feel like this is not taking into consideration factors outside of that individual, right? So their history, so their ancestral history, and then the systems and structures with which these folks are operating in. And so what they did was propose the pyramid or the conceptual framework that you see on your right. And they built in two other layers, they're sort of sub-layers, of when you're considering populations. For example, a lot of the studies that led to this addition of racing ACEs that takes into consideration, epigenetics, is the research that was done on Holocaust survivors and the research that has been done on African Americans or Black folks whose ancestry they can trace back into slavery in the United States. And so epigenetics is really important for us to consider because of the populations that we are seeing are disproportionately affected or burdened by the HIV epidemic. And yes, that is certainly Black folks, but a lot of other things I would consider we don't have time to go through all of them, but I would encourage you to consider are things such as poverty, when there's generational poverty in your family, that also has an effect. And so this is the importance of understanding epigenetics when understanding trauma. Resilience. So resilience is gained through protective factors that the person who has been traumatized possesses. Basically, the factors mitigate the harmful effects of trauma. And what you see on your screen bulleted out is different forms, different types of resilience factors. So for example, if I have experienced trauma and I have a great role model, I have a really good social support system, the chances are increased that I will be able to better cope with those traumas because I have these protective factors as well. There is no single accepted set of resilience set of components of resilience, but these are just a few that I've chosen. There are many different sets of resiliency. And so if you do decide to move forward with doing this work in trauma, I encourage you to evaluate the different sets and decide which one works best for your population. Intersectionality. So when I was doing this presentation once, someone shared with me a really great summary of what intersectionality is, and they said that things relate to other things. And simply put, that is really what intersectionality is, okay? So it considers different systems of oppression and specifically how they overlap and are compounded and how they cannot be examined separately from one another. And so what I did here was include a few social identities that usually are related to some form of oppression with the populations that we deal with and that we work with, okay? So gender identity. Does our client identify as trans, as a woman, etc.? That's, an important consideration. Sexual orientation. Do they identify as gay or as lesbian? That's also an important consideration, and so on and so forth. And so this is also really important to acknowledge, be aware of, and address when doing work to mitigate or to become trauma informed, because this concept, again, is really relevant to the populations that we know are most disproportionately affected by the HIV epidemic. And so now I am going to walk you all through what trauma can look like across the HIV continuum. And again, I just want to remind you all, as questions are popping up, I know that this is a lot of very rich information and I'm running through it very quickly for time's sake, but I encourage you all to type in those questions into the questions function, or if you would like to chat about it, I see that there has been some chat going on. So, or excuse me, there hasn't been chat. There's already been a question, but I encourage you all to keep on doing that. And also, please feel free to utilize the chat box feature. And we will do our best to get to as many questions as possible during the question and answer. And so trauma and the HIV continuum. So we're going to start off with pre-diagnosis. Past traumatic experiences can lead to engagement in increased risk behaviors for HIV transmission, such as sexual risk-taking and substance use. And then the contraction of HIV can be particularly traumatic if it's acquired during a sexual assault. Moving along to diagnosis or diagnosed. Although treatment is widely available, the experience of receiving an HIV diagnosis can be traumatic in and of itself. So the receipt of the diagnosis can be exacerbated depending on, number one, the method of delivery. Is this person finding out by letter or mailing, through a phone call, or is their partner disclosing it? Secondly, the person who's delivering the diagnosis, is that person being stigmatizing? Are they discriminating against the client? Or maybe they just lack training on how to best provide a diagnosis. And then number three, the health of the person receiving the diagnosis. So if this person is already experiencing a life-threatening illness at the time of diagnosis, this could further compound that stress or trauma that it causes. Moving along to ever linked or linkage to care. The experience of linking and engaging in care can be traumatic due to invasive procedures, insensitive providers, the cost of care, and navigation of health and medication benefits. Retention in care. People who've experienced trauma often have difficulty staying in care. While some clients are at risk of falling out of care, others may be calling multiple times a day. And despite the best intentions of providers, HIV care and support services, as well as prevention services, can potentially be re-traumatizing. And so what are some of the reasons they fall out of care? Well, there are providers challenging or discounting reports of abuse or other traumatic events. There's the labeling of their behaviors, such as sex with same-gendered individuals or drug use, as immoral. Also, failing to provide culturally responsive services, and the list goes on and on. That is merely a sampling of what we have learned. And then finally, viral suppression. So for those folks that are engaged in care that are living with HIV, trauma is associated with a variety of poor health outcomes, including treatment adherence issues, increased viral load, and decreased CD4 count. So hopefully that paints a better picture for you all of what being re-traumatized or triggered can look like for the populations that we work with. Vicarious trauma. So the professionals who routinely come in contact with trauma and suffering as a part of their work lives are also affected. And those people are us, right? They're us, there are subrecipients, there are Part C, Part D colleagues, so on and so forth. And regular interaction with trauma can take a toll on practitioners charged with supporting others through difficult times, or are somehow directly or indirectly working to end hardship and suffering for others. And we refer to these effects as vicarious trauma. Very similarly, very similar to the way that maybe a colleague is going on a vacation to a tropical island and you say, make sure you post pictures while you're gone, or bring pictures back so I can live vicariously, through you and through your vacation. Unfortunately, there's also the negative side of vicariously living through others as well. And so vicarious trauma happens when we accumulate and carry the stories of trauma, including images, sounds, and resonant details we have heard, which then come to inform our worldview. And again, this is very important to address because of the fact that Some of the folks on the line are providers. I mentioned the Ryan White side. There's, of course, the prevention side as well, the folks that are doing the testing and working on prevention efforts, increasing PrEP uptake, etc. You're interacting with clients and often hearing their stories. And as we learned earlier, there is a very good chance that the folks that we work with have experienced trauma. And so this does, in turn, potentially have an effect on us and on our workforce. And so vicarious trauma is a concept that I cannot sort of emphasize more of the importance of it. When we were developing this toolkit, many folks that we worked with really wanted to hear from NASDAQ or to see in the resources that we developed the importance of this, because you need to also, as you're becoming trauma informed, think about what that means for your workforce and making sure to address compassion fatigue or burnout. And I'll get into a little bit of what that can look like later on. So toolkit overview. And now I really highlighted the tool portion of this because, as I mentioned earlier, the second half of the toolkit is the how-to guide. And so that's what we're rolling into. The components of understanding trauma that I have just breezed through are included in the toolkit itself in much further detail. So I highly encourage you all to take a look at that toolkit and get even more information and context on what we've discussed. So the modules. So our how-to guide portion of the toolkit is broken up into 8 modules, and we want to shout out our friends at Trauma Informed Oregon who have created a sort of framework and roadmap to becoming trauma informed, which we have borrowed and adapted for the purposes of the HIV field. And this is the way and the framework that they've sort of broken becoming trauma informed into. And so what I'm going to do, for time's sake, we're not going to be able to go in through all of these in detail. I will be going through recognition and awareness in detail momentarily, just to give you all a sort of flavor of how to review the toolkit how-to guide and just to understand what you're sort of seeing as you go through that how-to guide. But what I'm going to do right now is provide you all overview of each of these modules and an action or two that you can take to address that module. Again, all of this information is in much greater detail. We've also hyperlinked to, it's got to be over 100 tools, assessments, and other resources in that how-to guide, so you all have a sort of launching pad to do this work and some tools to get you started on it. So starting off with recognition and awareness, take time to understand that services can be re-traumatizing for both the service recipient and the workforce, as we were just discussing vicarious trauma. Learn to recognize when and how services are triggering, and we're going to get into more detail momentarily about some actions you can take for that module. Next, foundational knowledge. Provide all stakeholders and staff with fundamental knowledge in trauma-informed approaches to form a common language and unified commitment. Some actions you can take here: provide all staff trainings on trauma-informed approaches and incorporate trauma-related content into ongoing trainings. Agency readiness. Implementing trauma-informed approaches requires a commitment from agency leaders and staff. Individuals within the organization must believe trauma-informed approaches are needed, appropriate, and possible given that the service setting and circumstances. Readiness, in what we mean by that in terms of psychologically, skills and knowledge, and other structural factors, are important to consider if trauma-informed approaches are to be embraced and sustained. An action you can take here: add trauma and resilience-related expectations to position descriptions. Process and infrastructure. Integrate trauma-informed approaches at the department, organizational, and/or clinic levels. It takes time and requires a lot of commitment and dedication, but ideally, a process that's supporting these efforts, these ongoing efforts, includes something around policy and practice. And some specific actions you can take here: identify and support internal leadership and champions. You can identify a work group to shepherd the effort forward, and identify a consultant or a consultant agency to train, assess, and evaluate your efforts. Next, gathering information and identifying opportunities. Conduct a trauma-informed assessment to identify opportunities for trauma-informed approaches, to highlight current trauma-informed practices, and to measure progress and implementation. Specific action you can take here: identify an assessment tool that will work best for you and your agency, schedule time to complete the assessment, and then after it's completed, communicate the results back to all staff. And again, I just want to reiterate, all of these tools and assessments we're encouraging you to do, we do have links to examples of them that you can pull from in the toolkit. Prioritize and create a work plan. Prioritize opportunities to become trauma-informed by utilizing your data. This will help your agency move forward without becoming overwhelmed by the possibilities. Take those priorities and develop a work plan around them. Specific actions you can take here: from your assessment results, identify a few areas where you'd like to improve. Brainstorm what you can do around those areas, and then create a work plan. Implement and monitor. After an organization has gathered information and prioritized needs, the next step is to implement the work plan while simultaneously monitoring the impact. And we just want to acknowledge here, although there is a lack of validated evaluation tools within this trauma-informed workspace, what we suggest is that there are assessments and surveys, as I mentioned, we linked to throughout the toolkit, and those at least provide process-based measures for consideration and for evaluation. Again, actions that you can take. Create a standing trauma-informed approaches agenda item for all staff meetings to share progress you've made on some of those priorities you identified. Once a new strategy has been implemented, provide opportunities for feedback from staff and clients through assessments or surveys. And then lastly, celebrate and maintain. As agencies pilot and implement trauma-informed changes, it is important to maintain commitment and momentum towards this cultural change through communication and celebration. An action you can take here: host a kickoff event when you're implementing really big changes. And then for Ryan White folks on the line, collaborate with the other parts in your state, share this toolkit with them, and invite them into some sort of trauma-informed approaches collaborative or something of this nature. And so that is an overview of each of the modules. The other thing I want to emphasize here is the way that we designed this graphic was intentional. There's no number 1, 2, 3, 4. There's not any sort of chronological order or linear process, because being trauma-informed or becoming trauma-informed is not a linear process. So what I encourage each of you to do is when you take this back and do this work in your respective health departments, because I have faith that all of you will do that, figure out where you all are. Perhaps your agency has already undergone a trauma-informed approaches training, and so maybe you jump in at agency readiness and you follow the circle along there, or you just hop around. Maybe you're not familiar, or your agency is not familiar with trauma. There was about 10% of you who said you weren't familiar with it. So I would suggest you jump in at recognition and awareness. But either way, make this work for you. Ideally, we would love to see folks implementing all of these modules. That is, of course, not realistic. So we really want you to take this and bend it and use it for, use it to meet you wherever you are at. And so now I'm going to pause. And before I jump into a more detailed explanation of recognition and awareness, we're going to do one more poll. And so the next question I'm going to ask, and you should be seeing that on your screens right now, is your agency implementing trauma-informed approaches currently? So we're talking about right now, is your agency implementing trauma-informed approaches? I'll give you all another 30 seconds or so to respond to that. Of course, the options here are just yes or no. All right, final reminder, there should be a poll on your screen. I'll give you a few more seconds to respond to that. The question is your agency implementing trauma-informed approaches currently? And the response options are yes or no. Okay, and I've now closed that poll. We have 58% of you all responding yes, your agency is implementing trauma-informed approaches, which is super exciting. And 42% of you responded as no, you're not currently implementing those TIAs or trauma-informed approaches. I'm really excited and to be frank, a little surprised that there's so many of you all. This is fantastic news for us. We'll be getting to this momentarily, but what I would love to do, we like to have a repository of the work that's going on because we like to share back examples of states that are, currently doing this work, so that it allows for sort of peer learning. So what I want to encourage you all to do is, for those of you who have responded yes, if you wouldn't mind in the chat box just stating your name or your agency and sharing one of the trauma-informed approaches that you're currently implementing. And we will potentially follow up with you just to learn a little bit more about it and make sure that we catalog your efforts. All right, so as I promised, I am going to go through one of the modules in detail, just so that when you go through the toolkit yourselves, you sort of know what you're seeing on this how-to guide portion, and you also know how to sort of navigate or utilize each of the components. And so this is a screenshot of recognition and awareness. As you will see up top is a little sort of blurb that's in bold that provides an overview of what this module is regarding and why it's important. What you'll see next underneath that are considerations. And so these are things to sort of be mindful of when you're working through this module. And so for recognition and awareness, as we mentioned earlier in understanding trauma, the services that we provide on both the prevention and care side can be re-traumatizing for both our clients and for our workforce, right, our staff. So we want to learn to recognize when and how these services can be triggering so that we can avoid those things. Next is the prevalence of trauma within the population you serve. One way to understand the prevalence is, as we mentioned earlier, to include ACEs in your consumer needs survey or in other surveys that you're conducting. And then lastly, another consideration is the prevalence of trauma and work-related stress within the workforce. And this speaks to vicarious trauma, which we also addressed earlier. The actions, I will not go through all of them in detail, but this is what I was referring to when I said we have specific items and tools that you all can literally just click on, and you'll see those lighter blue words or terms are the actual hyperlinks to tools, assessments, and resources that you all can hopefully pick up and start doing work on in your respective health departments. So we really wanted to make this as user-friendly and easy to incorporate as possible. And then finally, what you see on the right side of your screen is a state example. As I mentioned previously, we love to highlight and uplift the work that you all are doing. And so in this example, we see that Hawaii, similar to how we discussed Iowa was doing earlier, is incorporating, or I should say has incorporated, ACEs into their consumer needs assessment, which they conducted last year. And what they're going to do is, again, similar to Iowa, compare that against the statewide BRIFIS results. And this will, again, help them understand what, or I should not say what, but how prevalent trauma may be in their client population. And the utility of that, I think to a certain extent it's obvious, but maybe some not so obvious utilities is that if you have that data, this provides you something in your advocacy or education efforts in state level government or Congress to be able to justify the importance for addressing trauma within your programs and potentially advocating for additional funding to be going into your program specifically for trauma-informed approaches because of the disproportionate burden that your client population is experiencing. And so now we are going to just sort of close with a reflection that we want to share with you all. And this, I have to admit, is borrowed again from our colleague in Iowa, Holly Hansen, did a really great job sort of summarizing what we are working to do with trauma-informed approaches, right? Which is shifting the question from what's wrong with you to what happened to you. And I just want folks to pause and think about that for a moment. So what's wrong with you to what happened to you? What this does by shifting that frame of mind or that mindset that we take in the work that we do is that you are taking the blame away from somebody who is a survivor of trauma, and you are putting it onto the systems and institutions with which we are operating in, and acknowledging that the systems and institutions we are operating in are often what are responsible for leading folks into whatever trajectory they have been led into, right, in their lives. And so continue to ask yourselves and ask, you know, not literally your clients, but ask yourselves as you're working with your clients, what happened to them that's led them into this very place at this very time. And so finally, before we move into Q&A, I have one final poll question that I would like for you all to complete. Now that you've learned a little bit more about the toolkit and the modules, what I wanted to ask you all is, would you be interested in a future webinar on this topic of trauma-informed approaches? And so acknowledging that we've only reviewed one module today, would you be interested in learning in further detail about the other modules? So I'll give you all a few more seconds to respond to that. Again, the question is, would you be interested in a future webinar on trauma-informed approaches? And the response options are yes and no. About 10 more seconds to repeat that, to respond to that poll. Okay, thank you all for participating. We see that 96% of you responded yes, you would be interested, and 4% of you responded no. Those numbers make sense, as about 10% of you did say that you're already very familiar with trauma-informed approaches, but we're also really excited to hear that you all would like to learn more. So thank you all for responding to that. So moving into our question and answer portion and discussion portion. And so I am going to invite my colleague, Bianca Ward, who I believe is on the line, to moderate this session. Bianca, are you on the line?
Hi, can you all hear me okay?
Yes, thank you.
Wonderful. All right, so thank you all for still joining us and participating. So just for clarification, based on some of the questions that were answered already, slides will be provided and an audio of this webinar will be provided after the webinar is finished. The toolkit can be located on NASTAD's website at nastad.org, where you can go and download the toolkit. The link to the toolkit was also in the memo invitation that you received regarding today's webinar. So one of the questions, or actually comments, that we received was from Muriel Azaria Evans, and she mentioned that the Health Brigade has been focused on trauma-informed for over a year, and that they have trauma-informed leadership team made up of staff from each department. And so I was wondering, Muriel, if you feel comfortable, if you would, I can unmute you if you wanted to just tell us a little bit more about the leadership team or how that came to be.
Can you hear me?
Yes, thank you.
Okay, sure. So the TIL team in particular, it was a recommendation. We're a member of the Trauma-Informed Care Network, I think the Community Connection Network, which is the Richmond-based one. And it was a recommendation that so that it wasn't something that came specifically from our mental health and wellness, but it focused on the entire agency, that we had staff from all areas. So folks that work directly with clients, but also folks in foundation and administration. And so because we wanted to make sure that it was truly a broad approach to trauma, not just in the way in which for example, our medical folks or our mental health folks work with clients. That's part of it, but we wanted our policies and our procedures, the environment to reflect a trauma informed approach. So it's been really good because it's giving a broader eye on how we work and how the agency functions as a whole.
Thank you for sharing that, Muriel. And I think that's really important as we talk about trauma-informed approaches across the board, across the agency, starting with leadership, all the way down, making sure that everyone who is interacting with clients or making decisions based on the care and client's behalf are doing so in a trauma-informed lens. So thank you.
Sure.
Is there anyone else that would like to share what their agency is currently doing, if they have already begun to work to be trauma informed? And if so, you can either type in the question box, or if you want to raise your hand in the panel, and I can unmute you if you would like to share. Okay. So I have another question. I'm interested in coordinating trauma-informed activities within health and urban rural health departments, specific to women, which is great. Will this toolkit offer assistance on that level? And so, Rochelle, if it's okay, do you mind if I unmute you so you can give a little bit more detail in terms of what you're hoping to do? I can unmute you now. You are currently unmuted.
Okay, can you hear me?
Yes, thank you.
Okay. So I coordinate the women's program here in Georgia, and one of the things that I want to do is try to touch on like low viral suppression rates, low retention and care rates amongst women in Georgia. Typically, it's going to affect minority women, and so I'm looking to just kind of see what type of trauma-informed activities that I can develop and share with our districts for them to utilize in their clinics and in their respective areas.
Excellent. Thank you, Rochelle. I'm going to turn this question over to Mahalit a little bit, because I think what would be helpful is utilizing the toolkit as a whole, just starting with your agency first. But Mahalit, if you have any thoughts about specific modules that would speak more closely to what Rochelle is getting at, that would be helpful.
Sure. Thank you, Bianca. And thank you for that question, Rochelle. That's a really good question. And so I sort of agree, ditto everything that Bianca said. I think using the toolkit in its entirety would probably be helpful for what you're working to do. I would say specifically what you would likely want to start with is agency readiness. So understanding whether or not you have commitment from your leaders and from the agency leaders and then from your fellow staff members. And then the other part would be the assessment that we referred to earlier. And so you want to get a better understanding of what, confirm that these individuals would benefit from trauma-informed approaches. So you want to assess them for trauma. And then B, once you have a better understanding of what types of traumas, you can sort of tailor an intervention, so to speak, that you would implement accordingly. And so the two modules that I would encourage you to take a look at are agency readiness and then recognition and awareness.
Okay.
So if you can't go through all of them, those are the two I would suggest you start with.
Thank you.
No problem.
Okay, are there any more questions or comments regarding programming that is already being done in your agency or jurisdiction? Okay, I am not seeing any more comments, but again, the webinar will be available after the call, and the toolkit is available on our website for download at nastad.org. And so I will turn it back over to Mahalet to wrap us up.
Great. Thanks so much, Bianca. And so what I wanted to leave you all with are a few calls to action. So we understand that this can be very overwhelming. There's a lot to be done, and it probably feels a bit dense at times. So somewhere to start. So first of all, if you have not already, download the toolkit and review it. Again, you can find it on our website, nastad.org. The next thing, as I mentioned earlier, is incorporating ACEs questions into your client intake forms. If you conduct a needs assessment, incorporating it into that, whatever existing infrastructure you have in place to collect information from your clients, we encourage you to incorporate ACEs into that. Along with that, what I would suggest you do is also, you could easily go onto CDC's website. That is where information for BRIFIS is made available. So you can actually check and see on CDC's website which states have incorporated ACEs into their BRIFIS already. And so for those of you who are in states, and I want to say it's close to 20 of them, so it's a good amount of states, this will provide you a really great comparison against the general population. And for those of you who do not have it incorporated into your BRIFIS, that is totally fine. It still means something when you see a high percentage of folks who are reporting that they've had, 6 to 8 ACEs. And so that information and that data can still be powerful and important to you in advocating for the importance of taking a trauma-informed approach. Next, tell a friend, a colleague, whoever it may be about trauma-informed approaches. We really, really want to make sure that folks are spreading the word. And then lastly, we are asking your call to action because, again, we do use this information that you all share with us to improve our technical assistance in the future. So please complete the webinar. We ask you some information in there about technical assistance we can provide to you further. This can be beyond webinars. We also ask if there's some resources we can provide you that would be helpful. And then if you're considering really getting into action with this, what you're thinking you want to do for the next month or so. And so we encourage you to please complete those webinar evaluations. And this brings us to our conclusion for the webinar. We thank you all again for participating in the Trauma Informed Approaches webinar. Please feel free to reach out to me, Mahalet Kabeta. Again, if you have any further questions or concerns, you can find my information on NASTAD's website. Thank you all again and have a great week. Bye-bye.